Ortiz de Campanas de América. Y escuchen bien este consejo. Ten cuidado, es hora de cantar. Con la vacuna podemos ganar. Usando cubrebocas y distancia social, de seguro COVID-19 no nos puede ganar. ¡Aguas! Escucha bien el consejo que les voy a contar. Con el COVID no se debe jugar. Cuida bien la familia y amigos también. La vacuna contra el COVID nos puede proteger. Ten cuidado, es hora de cantar. Con la vacuna podemos ganar. Usando cubrebocas y distancia social, de seguro COVID-19 no nos puede ganar. Todos podemos ganar. Ten cuidado, es hora de cantar. Con la vacuna podemos ganar. Usando cubrebocas y distancia social, de seguro COVID-19 no nos puede ganar.
Hello and welcome to the 4th annual San Antonio City Fest. Today we've heard from mayors across Texas on leading through a pandemic. We just wrapped up a conversation on the city and county's $1.5 billion funding opportunity. And now we're concluding our first festival day with a conversation on the intersection of policing and public health. Thanks to the support of our sponsors, this year's virtual series is free and accessible for all. We invite you to share today's conversations to help ensure critical conversations like today's are reaching everyone in the community. If you find value in community conversations and events like this one, we invite you to support our nonprofit newsroom by joining our membership program today. Check out the link in the chat to donate. Before we begin, we'll take a moment to extend a special thank you to our 2021 presenting sponsor, the City of San Antonio. We also thank our engagement sponsors, such as Shiner Beers and CPS Energy, as well as our entire community of sponsors for supporting this year's event. For a full list of our sponsors, visit www.cityfestsa.org. And so let's dive right in, and I'll introduce our panelists today. We'll start with Eric Estrada, who's Executive Director of SA Clubhouse. Welcome, Eric. And Jenny Hixon, Public Health Administrator at Violence Prevention and Metro Health. Hi, Jenny. Mike Lozito, Director of the Bexar County Office of Criminal Justice. There's Mike. And Lieutenant Jesse Salame, Deputy Chief of Staff at San Antonio Police Department.
Oops.
Oh, there we are. Hi. Welcome all. Well, I want to start with giving our audience a chance to get to know y'all. Some of y'all work behind the scenes, some of you are in front of the scenes. So let's start with you, Eric. Tell us a little bit about yourself and how your organization kind of fits into this conversation about policing and public health.
Sure. I serve as the Executive Director of the San Antonio Clubhouse. We've been around for almost 20 years now. We are a not-for-profit organization that exists to support people who have experienced mental illness in any way that they need support in any sense that is not clinical. So we are a non-clinical organization. We don't have therapists or clinicians on the team. It's really more about meeting some of the social needs of our community, whether that is helping people find jobs, helping people get back to work, helping people find confidence, learn new skills, etc. And so that is a primary thing that we do. And we also provide training and direct services in some clinical settings through a program that we call peer support, a service that we call peer support. It is a growing workforce in Texas and across the country, and we help roll that out here in San Antonio and across the state of Texas.
Great, thanks, Eric. And I'll have you talk a little bit more about your work and about your organization's research and work in 911 mental health calls too later in the program. And Jenny, how about you introduce yourself? Hi there.
Hi, I'm Jenny Hixon. I'm the Public Health Administrator over the Violence Prevention section at Metro Health, the Health Department. We're the newest section within Metro Health, and we have 3 main pillars in our work: domestic violence, gun violence prevention, and then trauma-informed care, which also includes all of our work with early childhood and childhood abuse. Our section has grown very rapidly in the 2 years that we've existed, from about 13 people to, as of this morning, we're a little over 70 folks, and we're expected to double in the next year again, so that we can continue to grow the public health approach to violence prevention in San Antonio.
Great, thank you, Jenny. And hello, Mike. How about you introduce yourself?
Yeah. Good afternoon, everybody. Thank you for the opportunity to be here. My name is Mike Lozito, and I am the director of the Office of Criminal Justice. And basically, what that means is I work for the county manager's office and the Commissioner's Court of Bexar County, and I oversee programs such as the medical examiner's office, the crime lab, pretrial services, the justice intake facility, processing, the mental health department, reentry services, and work with the specialty courts also. So I work very closely with the judges and justice programs.
Great. Thank you, Mike. Thanks for being here. And Lieutenant Salame, how are you?
Good. Good afternoon, everybody. Thank you for having me today, and I'm happy to represent the San Antonio Police Department. My current assignment is in the Chief's office. I work as the Deputy Chief of Staff, and we work as under the Chief, and as part of the administration, we primarily focus on policy direction, on implementing changes within the organization, and also working directly with our partners, whether it's with Metro Health, the District Attorney's Office, Bexar County, working together to kind of come up with creative solutions to these problems that we all share. So I'm really happy to be here today.
Great. Thank you all so much for joining us today. Just to dive right in, I mean, it's obvious that there's been more attention given to alternative policing models since George Floyd's murder last year, in addition to law enforcement involved deaths in our own community. And I think are these approaches, like taking this new approach, kind of a health-centered approach to law enforcement, is that necessarily new? Is this as new as 2020, or have these conversations been going on before then? And that's open to anyone.
Well, I know that Jesse and I have been working very closely together. We were talking about this earlier today, actually, since the summer of 2019, when we really were focused on prevention of domestic violence. And so while I think that a lot of times the conversation is framed up as alternative responses versus police, really we look at it as what is the most public safety, and that incorporates prevention and then response and all of the things along the continuum. So while I think the larger awareness of this conversation is obviously shifted over time within the city around some of these issues, we've been working together pretty closely for a few years now.
Yeah, and Lieutenant Salame, I mean, what has been the department's kind of perspective on this? Has this been kind of a welcome revamp of how law enforcement interacts with the public?
Yeah, absolutely. And we've talked about it, Jenny and I think we understand that public safety is sort of the foundation on which all other public policies are built on. But public health is a big part of that. And being able to look at a lot of these complicated issues with the public health lens, it helps us to really understand why things are the way that they are. And it helps us to really try to get to the root causes of some of these problems that historically we've just responded to. And I think that that's something that to sort of expound on what Jenny said, kind of framing the conversation today and into the future, we need to look at this with all hands on deck approach, and with the understanding that for the community to be healthy and thriving, it's going to take everybody and all the partners that we have, the partnerships that we have yet to embark on to make this work, and to truly make this a trauma-informed city with a commitment to taking care of all of our residents.
Mm-hmm. Yeah, and I think that this type of approach is really, it's getting more attention, and then there's also more like concrete examples of where this intersection is coming from policing and public health. Like the one that exists locally today is Bexar County's SMART program. So I'm wondering if, Mike, you might be able to kind of give us an overview of this team that includes a law enforcement officer, an EMT and a mental health professional that goes out on these mental health calls?
Yeah, so Iris, I agree. The panelists, just I think that the major issues is expecting the police to respond to every all issues, and I think that's really, and it's become very um, with the detail of the types of problems that individuals have. And so one of the things that we found in developing the SMART team approach, which is the mental health, specially trained mental health deputy, the emergency technician, and a licensed mental health counselor going out on a nonviolent call. We found that a lot of it has to do with the 911 process itself. So you think of it, and that's kind of been there since the 1930s, when telephones and 911, or I don't know how long that's existed, but there's always been, the three typical responses are, when you have a fire, the fire truck goes out. If it's a medical issue, then the ambulance goes out and addresses it. And then everything else is police department, and it was really the opportunity to look at programs in Oregon, Eugene, Oregon, Cahoots program and the STAR program in Denver, which really looked at, okay, what are those responses, and are all the responses violent responses that you need to go to? What type are they? So basically what we set up was, working with the dispatchers to find out more information about the call that's out there and what's happening, and then being able to dispatch and develop this fourth button, right, which is now on the mental health end of it, where they can go out and they can assess the situation. So the mental health deputy is there to make sure everybody's safe, looks at the situation, but it may not be them as the first response. And then when they also go out, they're all dressed the same. They have like a green pullover that says SMART on it, and the police officer, their weapon's not displayed. It's on the side, kind of concealed. And the emergency technician is actually the person that engages first as they go up as a team to the individual. So it could be a family member saying, I'm really concerned about my son, he's really exhibiting these signs. I'm not sure, or he's doing this. As long as there's not a weapon involved, then the SMART team will go out, and that emergency technician approaches. And so you kind of think of it like when you go into the doctor's office, the things they make you do, right? You got to weigh yourself. They take your temperature, all these things that they do. Well, that's kind of how the emergency technician engages, is like, how are you doing? How are you feeling? Because we've had a few calls where they were actually medical issues of medications that somebody had taken, and they got a reaction from the medications that they took. So they weren't really mental health issues, but it could have, because of the way they were acting, if a trained individual like the EMT hadn't approached it, they were able to pick that up immediately to get the person to the hospital to save their lives. So those are the things where the health engages. Ask them, how are you doing? How are you feeling? Temperature. Make sure there aren't other things going on medically with the person, and that kind of eases the discussion to where the mental health technician can now talk to them, rather than saying, okay, what's your issue on there. And now they've kind of eased into it. They've taken care of the medical, and now they can ask them, oh, I see this is happening, or what's going on. And that really helps us to work with that person and engage them. And I think the main thing also is, when you're engaging, that you can work with that person to do follow-up, right? So it's also the emergency room thing. So when you go in to see a doctor and in an emergency room, they're there to take care of your immediate needs and get you safely to move on. Well, a police officer, when they're out there and they're on the scene, that's their thing, because they have the next call to go to, right? So they have other things to do in there. So they're making sure the circumstances are safe, secure, what they need to do, and then they're going to move on. So there's the follow up and those types of things aren't on there, that, and that's part of the SMART team is that they have peer specialists, they have counselors and so forth to get the person to programs. And what we found were about 70% of the people that we are working with weren't engaged in anything. So we engage them into services, right? So they weren't engaged in services. So it's like to prevent that next call is the process.
Well, and is that kind of how you're measuring success, and what led to the decision? I understand that it's going to be expanded to another to more teams.
Yeah, so to go 24/7, I see it. The success is that in the interactions that our SMART team has had, there have been no excessive use of force having to happen. And then the second thing is that we didn't arrest anybody on that process. They all went to like hospital, or they, the EMT took them to a doctor's appointment or something, so something engaged off of it.
Yeah, it's almost an arrest diversion type of program.
Yes, absolutely.
Well, and since you mentioned Cahoots and the STAR models, Cahoots out of Oregon and STAR out of Denver, I know that Eric, you've done a lot of research in this area, and kind of tell us about that work that you've recently done.
Sure. Yeah, we've had a relationship with Cahoots for about a year now, and some conversations about what options are out there and how can this look. And so I think everything that the county is doing is really exciting. It mirrors what seems to be happening in other communities. So Cahoots is the most well-known program, and after the murder of George Floyd, in conversations with their team, they said they'd had over 500 different communities reach out to them wanting to figure out how to do things differently. And what they found was that they just could not. They just couldn't respond to people. They said, basically, if we don't know you at this point, we can't talk to you. And so we were fortunate that because we had that prior relationship, we were invited to spend some time with them and some other people from around the country looking at implementing some of these models. We were also put in contact with the Denver STAR program, which I think has been a really exciting program to come along, because they're taking some of those ideas from Cahoots, but taking a more data focused lens, kind of like Bear County is doing, and looking to see what they can do to support the area of Denver. What was really interesting about the Denver STAR program is that, just like our SMART initiative, it started a few years ago with a multidisciplinary team, same kind of cohort of response with law enforcement and clinicians and EMTs. And a few years later, it was about 2.5 years later, the Denver police itself said, we probably need something different that doesn't require law enforcement. We don't always need this. And so one of the things that was really interesting for us to see as part of the data and those conversations with their leadership team is that in the first just 6 months of having a team that is just clinician and EMT going out there and meeting with people, they found that they were in a situation where they were pretty effective. They weren't having any kind of issues. And what was really exciting about that is about 35% of the calls that they were getting were coming from within the PD. So you had law enforcement people going out and being in scenarios saying, this isn't a scenario for us. You call in the STAR team, they can handle this. And so to be in a situation where about half of the calls that are being dispatched are coming organically from within other law enforcement officials, I thought was pretty exciting to see. And so I'm really excited to see what SAPD is looking to do and what the county is already doing. And it seems like if the data bears out the way it seems to be bearing out, that we may follow a similar trajectory in the future. And I think that's great, because I think that what makes these calls so different than maybe some of the other types of calls that people might get is that these calls, like Mike said, are just the beginning of a process. People need more help, And so when you look at the situation with Damian Daniels last year here in San Antonio, leading up to him being killed, if you read, and you know about some of the things that happened in that scenario, it's heartbreaking to think that it's an individual that over the course of a few days called multiple times for help. And we as a community weren't prepared to respond and didn't have a mechanism of helping. You read the stories about hearing things and seeing things like what Mike was describing. And you read about the deputies trying to help and offering to go in the house and look for, the voices that they're hearing. And it's heartbreaking that nobody there had the ability at the time to respond. And so I think the approach that we're taking, which mirrors what is happening in Denver, which is, rooted in some of the things that we saw in Oregon, are really exciting, and I'm really excited to hear that the county is moving, to 24/7 supports. And I'm interested to see how that data bears out, and if we end up going down the same path of saying we can continue to invest in that aftercare, what that would actually look like in our city.
Mm-hmm. Yeah, and I mean, you mentioned SAPD's forthcoming team that'll be rolled out. That program was included in this year. Well, now it's this year's budget. Lieutenant Salame, I wonder if you could kind of go over where the city is at in developing those teams. I know it's still in process, but I mean, you have a lot of examples to go off of, including Bear County's program, Cahoots, and STAR. Where are y'all starting off?
Sure, thank you. And with respect to all the information that they provided, I get it, and I think that we are well ahead of the curve when it comes to what a lot of other departments have done. We implemented a mental health unit, which was kind of a niche unit back in 2008. Nobody was like, who wants to do that? And I don't think you're going to find, a police leader anywhere in the country that says, yes, we should be doing mental health calls. That's what we want to do. So we've taken a lot of steps through policies over the years, having, the best policies, the most progressive policies when it comes to handling and dealing with mental health issues. We have our escalated mental health response that we implemented in September of 2020. And that basically is, talking about Mr. Daniels' case is also like when you have that opportunity to, when time and distance is on your side, slow it down. You don't need to go in there and escalate a situation where you're going to put yourself or you're going to put a consumer in a situation that is going to result in somebody getting hurt or losing their life. That is not something that anybody wants. And I think we all agree on that. With respect to, those policies, our pilot program that we're going to be doing is our multidisciplinary response team. And, we've already got components of this that we've been doing again over the years through STRAC and with SAPD. But we're going to be using our multidisciplinary response team to target our high utilizers of emergency detentions. We've got, we've identified, we have 100 high utilizers that get emergency detained 6 times or more in a year. That's something that needs to be addressed. And again, that's not necessarily the police department's role. Where is the other accountability on the other systems that are supposed to be helping us out? And the other part of that is our high frequency callers. You've got people that may not necessarily be a danger to themselves or others, but they are calling 911, multiple times a day. And it's not something that we can't respond to. We have to respond. So I think to what Eric said, it's a great point. And we are going to put clinicians in the dispatch center. I think Mike mentioned that too, to go to screen some of those calls out and determine where we can send different teams to. And our current model or policy or our model that our pilot program is going to consist of a SAPD officer, a San Antonio Fire Department paramedic, and a clinician. And I'll let Jenny talk more about kind of how we're going to determine where that clinician comes from, because that's going to be part of Metro Health. But we're going to work together. We're going to operate almost 24/7 and make the best determination on how we can proceed. From the city's perspective, from a department's perspective, while we agree that police shouldn't be their primary responders, as it stands right now, in terms of safety, the police are going to be a part of this team. I don't think that those are mutually exclusive right now, but we've got to develop these other systems first before we determine when the police should and should not be involved.
Right. Well, and yeah, Jenny, I wonder if you could kind of give us some perspective on Metro Health's role on these teams and also speak to some of these other programs that y'all are working on related to domestic violence.
So, and actually that's where I was going to transition. So I think there's a lot of conversation right now around mental health and the alternative responses. In San Antonio, we did an analysis where we looked at the Meadows Mental Health Institute did a great analysis where they looked at a lot of different police calls and things like that. And then our team looked at the domestic violence calls, and there were a few things that kind of showed up. The first thing is that there are about 3 times more domestic violence related calls than there are mental health calls. So if we're looking at the volume of people in our community that are being impacted by issues, it's one of those things where, you know, we want to make sure that we're building systems that can respond to everything. And so the challenge with domestic violence calls is that it also, if you look at the time of day, they're almost inverse. So mental health calls happen kind of in the middle of the day. Domestic violence calls are evening, overnight. So when we were thinking about building response systems, it's very difficult to build a response system that can hold both, because we also know that domestic violence is dangerous for everyone. So it is the most dangerous call for law enforcement. It is dangerous for the individuals involved in that situation. And our advocates that we have within Metro Health, we would not feel comfortable sending them out without law enforcement to anything related to domestic violence, because we don't want anybody to get hurt. So the role that Metro Health has been taking specifically around domestic violence is that we have 2 different wings of what we're doing in terms of response. And then we have what I would call the real public health approach. So public health is not generally your emergency responders. That's fire, that's police. We're not ER. We used to say part of the pandemic, if we do our job, no one knows we exist. And we did such a good job that no one knew public health existed for a very long time until there was a pandemic. But so now everybody knows we exist. And what we normally do is do a lot of upstream work that is not, we're not generally the people responding in the middle of the night. Right now we're doing a hybrid model. We have 20 advocates that were moved from SAPD into Metro Health last year. In this budget, an additional 10 have been added to that group of advocates, and the plan is to add an additional 10, so over the course of 2 years, to double the size of that team. They are not crisis responders. They receive referrals from the police, from fire, from the other sort of emergency response systems within our city to provide that follow-up support that Mike was talking about. So that phone call, we know, is the start or maybe the middle of a very long process that someone has been going through. There was just a study that was released that looked at homicides, domestic violence related homicides out of Houston. And what they found was that almost 90% of the people that were killed had had some sort of interaction with law enforcement in the 3 years prior. Importantly, almost half of those had also had interaction with medical care in the year prior. So when we look at the different systems where we need to be intervening, we have to be building in a lot more, like Jesse said, than just law enforcement and criminal justice. We know that a lot of victims are showing up in other places that we need to be making sure that they're getting that response and triage to us as well. So we have a newer program now, which is our case management program, which right now is very small, but which is going to be growing to be equivalent in size to the CRTs, which are based in SAPD, to provide long-term case management to people who are identified from any source as needing support. We built a relationship with our fire department where they're going to be able to do a screening from within ambulances and refer to us. We have a relationship with Bexar County Sheriff where they are already referring to us. And so the idea is that we're not the people that should be there in the middle of the night, because that's not what we're good at. But if you want to talk to us for a really long time, for as long as you want to, and as many times as you need to call to get you to the right services and to talk about behavior change, which is really what we're talking about, then that's how we can support.
Great, yeah, and we've been talking about mental health and domestic violence specifically, but I wonder if there are other situations, other 911 calls that this kind of public health centered approach could be applied to. It comes to mind like drug addiction, things like that, perhaps recidivism, restorative justice, things like that. I wonder if like where else can we apply this type of approach? And that's open to anyone.
I think that approach can, you mentioned substance abuse, because that's, the other thing that impacts me is the jail itself and individuals coming in. And that's usually one of our highest, arrest or drug related offenses. And then people with mental illness, you have the dual diagnosis with those individuals. So a lot of individuals are may have both, and they may be self-medicating, but really working on that front end system of substance abuse. Right now we have the South Texas Crisis Collaboration Law Enforcement Navigation System with STRAC, where they can police officer comes on to an individual, and they're having a mental health issue, so they have the ability to do emergency detention to a psychiatric facility rather than emergency room or the jail, which is really works out great. But one of the things is it would be nice, if we did have the opportunity to have some sort of substance abuse facility that can be same thing for emergency detention, which the law allows on there for substance abuse. But it's real difficult because we don't have it's a very expensive process, but it is something that we want to do. And I just want to say one thing too, backing up a little bit with Lieutenant on there, that San Antonio Police Department has been a leader in the nation, I think, with the crisis intervention training and a lot of the things that he was talking about. So these SMART initiatives have come on recently on there, but with Bexar County Sheriff's Office and SAPD have been leaders in doing that. And I know a lot of cities throughout the United States have come to San Antonio to look at those processes that they have had. So I think that's why these things like SMART Team were able to initiate really quickly. And I know that the stuff that the city's looking at right now to do on there that the lieutenant talked about is because we do have processes in places. And you could, like we were able to ramp up the SMART program in about 3 weeks, to be able to get that on the road and working through STRAC. So it's that collaboration within this community, I think, that is prime that's out there, working with the hospital CEOs, STRAC, the city, county, groups like NAMI, National Alliance for the Mentally Ill. So, I just think that we're poised in there. And on the substance abuse end, I know that you had some discussions on the ARPA fundings and where those would go. And I really would like to see, Judge Wolf put together the task force on behavioral health and criminal justice. And so the group has met, and the city has participated in that and made recommendations, but they also are making recommendations from the task force to look at pre-crisis, right? Like we have a lot invested in crisis services, but for services like Eric provides, with the Clubhouse and those types of things where you can, catch people before they become a crisis and then don't end up in the criminal justice system or expensive in the hospital. So access to services, I think, is really important, and substance abuse, starting to coordinate that, because you really don't see any kind of system where all the providers are on target with like we do with the mental health end of it. So we'd like to really try and work on that to get substance abuse as a key and collaborate with all the providers to make sure we have enough beds within our community.
Mm-hmm. Well, and Eric, I wanted to ask you, given your experience in mental health, with working directly with people with mental health issues, why is it so important that we start to approach mental health calls differently?
Yeah, I think a lot of times what we see with our folks is, people have unmet needs. And I think if we're thinking that we're going to respond in one moment and address the issue, it's probably not going to happen for most people. It's just like Jenny said, really inspired by the work that they're doing, which is if you need help for a long time in lots of different ways that we don't really maybe understand upfront or immediately, that's what they can do. And I think on the mental health side, we see a lot of that. We see that with the work that we do, for example, where it's non-clinical, but yet has an impact on people's mental health. People feel better when they're expected somewhere, they're wanted somewhere, they're doing something meaningful. There's a set of community around them that is supportive. That is not a thing that is easy to deliver to somebody on an immediate call. You can't show up to somebody's house and make that change. Not law enforcement and not the Clubhouse. Like no one can show up one time and talk to you and then you're going to be fine. This is a process that can take a long time. And like y'all said, everyone said so far, it's about getting upstream and getting in there pre-crisis. And you end up having effects that you don't even are really aware of. And so I think that's why it's got to be a little bit different.
Yeah, and then there's a lot of overlap in these systems too. Like I think Lieutenant Salame and I were talking about the other day. A call could be a mental health call. It could be regarding homelessness. It could be regarding drug addiction. It could be and also domestic violence. So it's kind of hard to see where all the pieces to fit and to make sure that people have a touch point in their lives to get the resources that they need. How do we build that system? I think that's a big question, but if anyone has a suggestion, let me know. I'm looking at you, Jenny. No.
Yeah. I mean, I think in a perfect world, which is far from where we live, but I think there are two things. One, I think something that Eric said about, that a lot of the times the things that moves your health has nothing to do with clinical services. In public health, we say that health is the outcome of your entire lived experience. And so it's not seeing a doctor, it's not seeing a clinician, it's not anything that actually is the biggest change in your health. It's the community you live in and the community you have around you. And so if we really want to impact a lot of these issues, I think that a lot of the work that we do is really trying to catch people when they're already close to the waterfall. But backing up and looking at what are the other things we can have in our community that make a big difference. Access to stable housing, access to living wages, making sure everyone has equal opportunity in terms of educational opportunities. These are the things that we know are actually the most predictive of health, all types of health, mental health and physical health. But those are the places where we know that our community continues to fall behind other cities in our country. The second part of your question is, what is a response system that looks like it's able to deal with all the complexity? I think if we're really trying to build towards that, it's going to take a big vision about what it means to be trauma-informed and to be trauma-informed in the middle of a crisis. So understanding that, like you said, if you come up to someone and they are homeless because they are experiencing domestic violence, and so they're living in their car. And the way that they're coping with living in their car is that they now are using substances because they just can't sleep in their car at night because they're so scared that they're going to get found. And so the only way they can fall asleep is if they drink enough to be able to go to sleep. And now they also have some underlying depression that's shown up, which is very common in people that are experiencing violence. So now you have somebody who has this whole litany of issues. And if the person who shows up only knows how to deal with one of them, or doesn't know how to triage, because maybe the domestic violence is very dangerous, but that might not be their biggest issue tonight. Their biggest issue tonight might be being somewhere safe to sleep. So we have to build systems that are able to triage and that are able to understand that a lot of the times the way that people respond to trauma has been criminalized in our society because we don't have a better way to deal with it. And so a public health approach and a health approach, we're less concerned with, or not at all concerned with whether or not your behavior is something that is a crime. We're concerned about whether or not it's harmful to yourself and to our community. And there's a lot of stuff that people do that's harmful to themselves in a community that's not a crime. And there's a lot of stuff that people do that's a crime that's not harmful to anybody. So that's the system that we're trying to understand is how do we sort of decouple well-being from the systems that are more about sort of community accountability, and understand that sometimes we haven't built systems that can hold both right now, but we're working on it. We're continuing that conversation.
If I could add to that. So to Jenny's point, the situation she described, anybody that's here and anybody that's watching could probably guess where that first call is going to come into, and who's going to be the first person to respond to that. It's going to be an officer. And so to Jenny's point, based on just that sort of that's a regular scenario, and so having a trauma-informed department, which is things that we were talking about in 2019, to have everybody sort of trained to recognize that we've got to build that system, because everybody is so accustomed to, if you call 911, you're always going to get an answer. We saw that during the winter storm. Very little of what we did during the time that the city was shut down had nothing to do with responding to calls or any criminality. We became, we were drivers. We were taking people to the hospital appointments, getting prescriptions, things like that. And so I think that's sort of kind of the basics and the foundation of what a truly trauma-informed police department looks like, being able to meet people's needs and understanding that we're probably not the people to call, but also having the community recognize too that there's another alternative system in place. And once that system comes up, whatever that number is, or however we get them to that right individual, and then if you need us, call us. But we shouldn't necessarily be the first people to respond to that. And so I think that's where public health and public safety intersects, and then all the other things in between.
Right. It's kind of that. It kind of leads me to one of my questions about crime prevention. Jenny, you mentioned, that we're trying to get people to stop from going off the waterfall. We need to address all these upstream causes. So at the end of the day, it sounds like it's going to be a whole network of organizations, departments that are kind of responsible for crime prevention, not necessarily, that's not necessarily a role that SAPD should fill. Does that sound right? Or for Jenny or anyone?
Sure. And I mean, I think I would even take it out of the framework of crime, because I think a lot of the reasons why things are criminalized are because they hurt people. And so what we're really thinking about is, how do we have the most safety and well-being for the most people in our community? That's a very different question from how do we stop crime? Because I think that the most, crime is almost a byproduct of all these other things. And so there's a lot of people that get hurt and they never report it to the police, but that hurt happened nonetheless. So that's, I think, when we are thinking about building these systems, it really is building all those upstream responses, identifying what are the places where we're still not where we need to be as a community. And we know that that's why people are stuck in situations where violence occurs. And the work that we do is stand up, for example, where they go out on our, violence interrupters, and they go out in the middle of the night and they talk to people who might be doing retaliatory crime. A lot of the work that team does has nothing to do, I think, as Eric said, with crime. It has to do with like getting your GED, or helping you enroll in a job training program, or all of these other things that help people live lives that they want to be living, and not be in situations where violence is brought to them, or where they might use violence against another person.
I think one thing too is adverse childhood experiences. Working one of the things we have a grant that's recast, and prior to the pandemic, we had the opportunity to work at Sam Houston High School with having wraparound services, social work, and mental health. There, working with the kids they had really high referral rates for disciplinary action. So it's part of it is what they call the restorative disciplinary process. Not asking Susie, why she did that, but a little more into, I didn't do my homework and all this other stuff. Yeah, because my mom's in the hospital or she's in jail and I'm taking care of 3 kids and I'm barely could get here. I didn't get my homework done. Why were things happening, and how can we interact with that person to get them the services? So there are so many children out there with a lot of trauma issues, but they don't get resolved, right? So it's like, how do you heal and move on? Because you can't change what happened, but you can change how individuals deal with it. And a lot of times, if they don't deal with it, they're angry, and they're angry at the world, and they're angry, and they become parents and become angry parents, and the same repeats itself. So, I really think one of the things too is working with the children, and working with the schools on more restorative disciplinary, doing things called circles and these types of working with the trauma that's there. It could be a real preemptive way of addressing. So as more kids graduate high school, as more kids do this, then we can have better outcomes and fewer people interacting with the police.
Great, thank you. I have a million more questions to ask you all, but it's time to go for the audience Q&A time. If I'm correct, Laura should be queuing up a question. All right, this is from Amanda Morgan. What is the city doing to alleviate the lack of mental health inpatient beds in the city? I work in an emergency room where we are often having patient holds waiting for beds for several days. Each hold requires a one-on-one sitter. The requirement of taking a staff member away from the functions of a busy ER to sit with mental health patients is burdensome and an already taxed team is irresponsible. I wonder if Eric, maybe Jenny, you might have some ideas on this. Or Mike.
I can respond. Actually, on the task force, that's one of our recommendations. What's happening is that they're waiting for the beds because there are individuals that have real severe mental health issues, and they're taking up a bed. And what we need to do is really start working on having something for the person with the very severe issues on that end of it. So one of the recommendations was for our ARPA funding that's going to go in front of commissioners is that we increase some of that capacity for those individuals that have real high acuity and are actually taking up the beds that are available within the community. So we're I think it's a $14 million proposal on there to try and address that. And part of that is because the state hospital, their function is not doing what it was set out to do. They're becoming more forensic. And what I mean by that is that individuals that go into jail and are not competent to stand trial have to go to a state facility to have their competency restored. Well, like in Bexar County right now, I have 159 people waiting to go to a state bed. But when they do go in, like the state hospital, it used to be about 10% forensic and about 90% of it was civil beds, for the community. But now it's flipped, it's like, I think it's 70 some odd percent forensic and 30%. And that catchment area for the state hospital is 29 or 30 counties. So when you're trying to get your bed, that's why you're seeing what you're seeing is we don't have that luxury anymore. Other things we're going to be looking at is, does Bexar County need to have its own psychiatric hospital? University Health Science has our University Health Systems, which is kind of the county hospital system, has engaged. They put out an RFP and they're working on selecting a consultant to come in and tell us what we need, because Harris County has done that and Dallas County is recently got funded to do something like that. So we may need to look at it locally here to have those types of beds available to increase, so individuals aren't waiting in emergency rooms for 7 to 10 days to get a bed, to get help, really.
Yeah, I mean, that you're talking about a week of resources in an emergency room.
Yes.
Yeah. I think we have another question from our audience, from Lance S. How closely do your organizations work with peers outside of San Antonio that are doing similar work with regards to mental health services? It's open for anyone. Go ahead, Eric.
So I don't know if peers is peers in the mental health peer space or peers as in other organizations doing similar work. And so I can speak to one of those. I can speak to on the mental health peer side if that is what the question is about. And that is, that field is still different things. There are some really great efforts coming down from the state to get people across the state working together better. But for the most part, most of the mental health stuff is happening locally in our community. So we might have some communications for best practices or for training or for those kinds of things. But for the most part, most mental health things are local, and most of our communities every community in Texas has a local mental health authority. And so most of the work is localized ultimately into some geographic area. Like Mike was saying, the state hospital catchment area is like 30 counties around here, so there is some work that is happening across those counties. But I don't know that necessarily means that we're working with the people up in Dallas or Houston, besides these kind of individual relationships.
Jenny, do you have something to add?
Sure. I think so specifically around different types of response and then also a violence prevention approach to public health. Our department, our section in the work in San Antonio, we're the largest in Texas. And even though we're also new. We're starting to be one of the oldest now. And so we've coordinated with Houston, Austin, and Dallas, and Fort Worth actually came down and visited before the pandemic, to kind of talk about what we're trying to do here. I think as Mike mentioned, we're taking a trauma-informed approach. So within our section is also the South Texas Trauma-Informed Care Consortium and work around child abuse prevention. So it's that life course model that's unusual. A lot of violence prevention sections are focused on kind of the stuff that's later downstream, and we're really trying to keep that focus on the whole system. For the alternative response systems, earlier in this summer, although it's a blur, I think, we talked to a lot of different communities and public health departments that were looking at how they could support on-scene response. Albuquerque's doing a lot of interesting work around this. We talked to the Vera Institute and a lot of other sort of communities. I think, as Eric mentioned, it's all new approaches that people are taking. The thing that's different in what we're doing in San Antonio and where we're continuing to try to meld all these things together is that we're not willing to let go of domestic violence as being a part of this whole conversation, because of exactly what you highlighted earlier, that we can't silo things, or we're not building a real responsive system, and we're going to keep people falling back into the same holes. So that has been, I think, where our community has not found another community that is looking at this in the exact same way. Because we do see all these issues as part of a big story about people needing support for their whole lives.
Well, and Lieutenant Salame, I saw you nodding your head a lot. I know you work very closely with Jenny and Metro Health and Nick. But I know that SAPD and McManus, the chief, kind of travels around and regularly talks to other outside organizations. How often is that conversation about mental health? And
right now, right now, that's been sort of the talk with every, we deal primarily with major city police departments. So every major city police departments, they just had the Major City Chiefs Conference last week, and that was like topic number one. Phoenix has come down to visit. Dallas has come down to visit. I think everybody's watching what Albuquerque's doing. The verdict's still out on that, but they've developed their own program. And I think that's sort of what we're doing here, because there's not a one-size-fits-all approach, especially when it comes to the varied communities and the needs of different communities. And I think that every department is in different places as well. And so you have to be able to set attainable goals and meet those challenges. But to Jenny's point, I think this is like probably the most important thing that we've been dealing with, because again, there's a lot of overlap with domestic violence. There are some, if there's not mental health issues, you're going to have you're going to encounter some, or you're going to develop some by becoming a victim or a survivor of domestic violence. If there's not substance abuse and alcohol issues, those are usually all connected and tied together. But domestic violence is sort of the worst case scenario when it happens, and by the time that we're involved, our choices are fairly limited, and it's going to be to have to take a law enforcement action. And so what we're trying to do by working with public health, with Metro Health, and taking that approach, is trying to catch these things, trying to stop these things, and trying to break the cycle. And unfortunately, that's not something that's going to happen in a year or two. That's going to take a generation to correct. And so the work starts now. And I think the foundation that we laid today, and working with all of our partners in the county, working with our outside groups like Eric's group, everybody's sort of coming together and making some real common sense proposals, and having things to work in a way that makes sense for the city, and ultimately makes all of us safe, and breaks that cycle of violence.
Great.
On my end, we have a group that kind of informal, and it's hosted by Sam Houston State University out of Huntsville, and their Correctional Management Institute. So we have the similar positions as mine. There's a director in Harris County, Dallas County, Tarrant County, El Paso County, and Travis County, and we get together twice a year. Matter of fact, in November we'll get together, and so we do meet to discuss these issues like mental health and court services, and a whole array of issues for communities, and they've been able to bring in individuals from all over the United States, subject matter experts, to kind of work with us and talk to us about different best practices and processes throughout the United States. So that's been very rewarding, and it has an impact because those are very large areas, about 50% of the population of the state of Texas.
Well, and Jenny, when we were talking earlier this week, you mentioned this new UHS-funded hotline with STRAC. I think it's called MedCom, and it's not something I'd really heard of before. I'm wondering if you could kind of share the details of that with our audience.
Sure, and I think actually Mike referenced it earlier. LENAV, I think all of us call it something slightly different depending on the take. But so it's the hotline that STRAC has operated for a while. That helps folks, that helps law enforcement with navigating the mental health system through a partnership with University Health, which has been a fantastic partner in all of our domestic violence work. They were able to expand that to allow for a lethality screening that supports Bexar County Sheriff. So if there's an officer that goes out, a sheriff's officer that goes out, and they find it's a family violence situation, they can call in, same number that they're already familiar with, same system they're already familiar with, and STRAC is a known and trusted community partner. They're walked through that lethality screening. If the individual that they screen screens high or medium, they're offered different resources, and they can also refer that person to our team. So it's a way that it's the partnership between STRAC, University Health, BCSO, and our health department. And then we also have some other great community partners that are the Family Violence Prevention Services is willing to receive those folks. If they're not able or willing, or maybe that's not a good fit, we have other housing available for them. And so it's a pilot. We've been doing it for a couple of months now to see if it's something that we can roll out on a larger scale. But so far it's been very successful, and it helps the officers on scene feel comfortable that they're screening people appropriately, and that importantly, when they screen them, that they have somewhere to send them. Because we know that, especially, for example, with healthcare, we give people all these great screening tools. They identify somebody as having a problem with domestic violence, and they're like, so what do I do now? And so we're trying to build all these systems at the same time as we're increasing access of evidence-based screening. We then have to build the response system. So when you do find somebody, you can actually help them and not just say like, well, I just want to let you know you're really a danger for some bad things happening, but best of luck. So
now, is that a program that you saw somewhere else and tried to replicate, or is that something unique to our system?
So it's a little of both. I think it's there's a model that's out of Baltimore, Maryland called the Lethality Assessment Protocol, which is somewhat similar. We sort of borrowed some features. Our community has, when we sort of did assessments earlier, our community has a lot of resources. And so we're sort of the mind that instead of trying to build, we have a lot of resources that aren't well connected. So instead of building new things, we're just trying to figure out how to build better connectors so that we can more appropriately triage in the moment those types of things. So that's kind of where this model came out of, is borrowing from that Maryland program that's highly successful, borrowing from communities that are using these lethality assessments, and then building it into what we have here, which is STRAC, which is a fantastic partner in all of these efforts, and really can stand these things up quickly, as Mike said.
Great. Unless anyone has anything else to add, I have kind of a final question that might be hard or easy. I don't know. But I'm curious, what can the average person do to not solve the problem, but to help support these systems and to make them stronger? Should they, call their elected representative and have them vote for a certain thing that's coming up, or what is something that you tell people to do in their day-to-day lives that could really help these systems? Anyone want to volunteer to go first?
I'll go. Yeah, I think it is. It's like the leadership, that makes the decision on the funding. That these things are, they do need to hear that these things are important to them. outcomes are really important to them on there. But that makes a big difference, you know, with, you know, I know the leadership we have with the Commissioners Court, they're very focused in on the domestic violence end of it, and mental health are some of the key things, substance abuse that they want to see out there. And, you know, that's, to me, is the best community safety that you can have. If you can take somebody that has an issue, get them help so they aren't out there again, that's the best way, you know. So it's like, you know, I always talked about, you know, it's like building freeways with no exits. You know, it's like the criminal justice system. It's a system, but it's not planned all the way through. You know, it's like, it could be hiring police officers and deputies, but did you hire, you know, or did you expand your funding for treatment, or did you add treatment beds in the community, or did you do this, you know? And it's like, you know, we need to look at it like when they build a freeway, they plan everything down to the detail, you know, to the penny. And the system, the criminal justice system, needs to be a system itself, and not be in silos or pieces. And, you know, making sure that if we do one thing on one end, then we need to react on the other end, be in step.
Sounds like a complicated highway.
Yes, it is.
Lieutenant Salame, go ahead.
I thought Eric was going to go. I was going to want to cut him off, but anyway. Yeah, I think to Mike's point, that's probably the biggest sort of roadblock that we've had is recognizing that, you know, the system is a criminal justice system. We're one part of it. These problems don't start with public health and end with public safety. These things are all intertwined together over a lifetime, and the end result is maybe where we're getting someone and having just this crisis in their worst day, and sort of being prepared for that. But I would say, I guess for me, I would make it just a little more personal and just say that everyone should just be more empathetic to other people's situation. There's not a person that's probably on this panel, there's not a person that's watching that hasn't personally been impacted by domestic violence, by substance abuse, alcohol abuse, mental illness, or homelessness. You have, I guarantee that we've all personally dealt with one, maybe more of those situations. And so I think being empathetic to that and not automatically criminalizing folks or judging people for that is a big, important step to just sort of making sure that represents who we are as a community. And that's what San Antonio is. And that's why I love the city.
Same.
I think, Jesse, you literally took my answer. So that, you know, I had a leader, a really high profile person in the community here recently say something to that extent of, I used to see people on the street and I would, you know, kind of turn away and not think much about it until I realized that this was happening in my own family. And then all of a sudden I'm like, that I can't look away the same way that I used to. I think just getting to know people out there and realizing that this touches all of us, everything that we've all talked about here affects us all in different ways. So.
And I think I would have sort of the two different ways to look at this, which, you know, we're city employees, so we can't tell you to do anything about voting or who to support anything. That's not our role. But I think that what we can say is that when we're thinking about it from a systematic perspective, there are literally no easy answers here. And I think right now, if there's anyone as a community that is trying to sell us an easy answer, we as community members need to be asking more complex questions. Because I know all of us who are on this panel, we all work on these things. And if you ask me about my opinion about anything, there's almost nothing that I would be a hard yes or a hard no on, because it's too complex. I think the second thing is that if you have someone in your life who's going through any of these issues, no one should go through that alone. These systems are complex. They are difficult. They are not built for people. They're built for structures. And so walking with another person through these systems makes all the difference in the world. And that includes if there's somebody that has been arrested and is, you know, going through the criminal justice system. It's not, you know, turning your back on those people and walking with them through that process because that in and of itself is supportive of making sure that people don't continue to have relapses, and that people don't continue to stay back in the system if they know they're not alone. That social connection is the most important thing that we can do, and that is something anybody can do in supporting the people in their lives that need help.
And if anyone in the audience or if is experiencing these issues with domestic violence or mental health, who should they call? Is it 311, Jenny?
311 is always a great place to start. Family Violence Prevention Services has, their 24/7 hotline. I think 211 also has a really impressive array of resources. There's also the national hotline number, which I should know by heart, but I don't anymore. But there's a lot of different options for people out there. But I think the important thing and what we know is that the most, when people actually get safe, they get safe because of their friends and family. And so if you're a family member that receives that call or a friend that receives that call, don't give up on people and respond. And if you're someone in that situation, reach out to those people that you trust, because someone will step up and help you.
Great. I think that's a really good place to leave our conversation today. Thank you all so much for joining me. I think it's been a really great conversation. I hope y'all learned something. I know at least 2 of you met a new person today, so I really appreciate it.
Thank you for having us.
All right. So that concludes our first day of San Antonio City Fest. A special thank you to our 2021 presenting sponsor, City of San Antonio, as well as our engagement sponsors, Shiner Beer and CPS Energy, and to all of our sponsors for supporting this year's hybrid event. We look forward to seeing many of you tomorrow at our keynote luncheon featuring Char Miller and Henry Cisneros. For those who can't attend the luncheon, be on the lookout for our presentation recording later tomorrow afternoon. On behalf of the SA City Fest team, thank you for staying civically engaged with the San Antonio Report. Bye.